Welcome everybody. Welcome to this webinar that is being hosted by the charity Wellbeing of Women, which raises vital funds to improve research into all aspects of women's health. My name's Lesley Regan. I'm an obstetrician and gynaecologist, and I work at Imperial College in London at St Mary's Hospital. And I'm very proud to be able to say that I am the new chair of Wellbeing of Women. I'm enormously appreciative of being able to invite you to this webinar, which we've devoted to one of the commonest complications of pregnancy, miscarriage, a problem that affects so many women and their families, and yet there's still so little known about it. And it's a great pleasure to be welcoming Lucy Bannerman, who's an award-winning journalist with the Times, to be my other panel member today. And I believe that over the next 45 minutes or so, we're going to have a lovely discussion about all sorts of aspects. But just before we launch into talking to Lucy, because that's really why we're here, I wanted to just thank all those people who have signed up today, and I believe we have over 200 participants. Thank you very much to those of you who have donated, and thank you to our corporate partners who've also contributed and helped to make this possible. Please visit our website, wellbeingofwomen.org.uk. It's so important that you get to know us, come to more events that we're hosting, and also sign up to receive our newsletter. We really do want to ensure that really vital health research is taken up into every aspect of the woman's life course. So as an obstetrician and gynaecologist, I've been very interested in how we empower women to help themselves look after themselves, because women make up 51% of the population, but we know that they actually influence the health behaviours of everybody else in society. So one of my strap lines is, when you get it right for women, you get it right for everybody. So let's make it better for women and easier for them to help themselves and everybody else around them. I just need to make a few housekeeping points. The session is being recorded, and subsequently it will be available for you to watch on YouTube. We're going to have question and answers at the end. Please submit your questions in the chat box. The chat, not the Q&A box, the chat box on your screens. We've already received a few. Thank you to those of you in the audience who have been so enthusiastic that you sent your questions ahead of time. And I hope that the discussion that Lucy and I are going to have now will inspire some more questions, because we really do want to try and address those and help women to access the help that they need to cope with miscarriage, which is the commonest complication of pregnancy. One of the reasons I'm so thrilled to be the chair of WOW, or Wellbeing of Women, is that when I was a very junior doctor in training way back in the 1980s, I was working in Cambridge, and it was a very large hospital, and it seemed that almost every night I was on call at 3 or 4 o'clock in the morning. I would be trying to dry the tears of a woman or a girl who'd come into casualty miscarrying. And always the question that she asked me was, why did it happen to me? And I went to the textbooks like all good trainees do, and there really wasn't very much there apart from to say, this is nature's way of sorting out problems. And yes, we knew that the commonest complication, or commonest cause for miscarriage, are genetic abnormalities in the babies. And that's why the miscarriages usually occurred so early. But I think it's important to say that there was very little else known. I think the situation is much better now, thanks to Wellbeing of Women, who were called something else in those days, but they gave me a startup grant to do my very first research project into miscarriage. And from that, I've managed to develop a research program and a research team who now see more couples with repeated miscarriage, I think, than any other clinic in the world. And I'm very proud of my research team. They've actually developed some of the really important investigations and treatments for the treatable causes of miscarriage. So I think without further ado, I think it'd be really helpful if I was to move on to Lucy now. We're very happy to talk about other aspects of miscarriage and how common it is and what the causes are. But I think it'd be lovely, Lucy, to have you, if you like, set the scene as a miscarriage sufferer, somebody who's experienced this problem and had to live through it. And thank you so much for joining us today.
That's all. Thank you, Professor Regan, and thank you.
It's got to be Lesley.
Lesley. Thank you, and thank you to Wellbeing of Women for inviting me along today. Yeah, I mean, it's staggering when you think about it that only 2.1% of all UK health research funding goes towards women's reproductive health and childbirth. I mean, pregnancy and childbirth are not niche issues. You know, all of us, every single human who's ever lived is here as a result of pregnancy and childbirth having gone right. So it's just really odd when you think that so little money goes towards researching what happens and why things go wrong. And I think miscarriage in particular often gets filed away in the category of one of these many things that women just have to suck up and get on with, and we just have to grin and bear it. But the reward for grinning and bearing it is that fewer people seem to then, you know, donate money to funding it to make things better. So that's why the work of, you know, well-being of women is so important. And yeah, I'll just start a little bit by sharing a bit about my story, which I wrote about in the Times a few months ago. And I had my first child, my son, when I was about 34, and I was very lucky that he breezed into the world without a problem, without any drama. And it wasn't until a couple of years later, aged 36, when I started trying for my second, that you know, there began 4 bewildering years of miscarriage, unexplained infertility, and an ectopic pregnancy that nearly killed me, before I went on to have twins through IVF. And I think looking back on it, it was possibly the miscarriage that maybe hit me the hardest, because it was an early one at around 9 weeks, and it happened in that first trimester that's sort of shrouded by so much secrecy. And I think that made it really hard to deal with. And, you know, in my naivety, I thought I knew what miscarriage was. I thought it was, you know, an awful event that was, you know, done in a day. And it was like, you know, thinking for a moment you'd won the lottery and then realizing you'd misread the ticket numbers and that you wouldn't be having that gloriously imagined future after all. And, you know, having to deal with the disappointment and get on with things. I hadn't realized that it could be a sort of surreal bereavement in slow motion. And in my case, it was like a three weeks long. It started with that kind of stop the car, blast, violent, you know, blast of blood. And I thought, that's it, it's all over. Went to the hospital expecting the confirmation of that. And to my surprise, when I got there and in the sort of scan room, the lights dimmed, the gel went on my belly, and the sonographer, you know, there was a heartbeat. And the sonographer said, oh, you know, this little one's doing fine. Yes, there was a shadow of bleeding in the background, but that can correct itself, often does. Just keep an eye on things. And the next 3 weeks, it was just a very strange experience of being a zombie in your own life, wondering, you know, who was winning the battle. You know, was it the baby or the bleed? And there was like surreptitious trips back and forward to hospital until finally, you know, 3 weeks later, there was no heartbeat and it was over. And it's at that point that the sort of surprises, the shock really starts, because there's a reason people don't talk about the business of failing and of expelling a failed pregnancy, because it's brutal and physically traumatic. It's a brutal, visceral experience that's hard to talk about. And yeah, I remember, you know, a few weeks later, you know, it went on for weeks and weeks and weeks afterwards. You're dealing with the physical aftermath. And I remember go and visit a friend to, you know, try and cheer myself up, and meeting a male acquaintance who started chiding me and having one of those conversations that I'm sure will be familiar to many women, possibly in their 30s, of saying, you know, oh, well, when you're hurrying up and having your second, you don't have much time left, you're not getting any younger, when are you having your second kid? And I just felt like shrieking at him and, like, you know, pulling out the lady nappy that I was having to wear at the time and just shouting at him and saying, here's the remnants of my second child. And I was so furious, but I did what I imagine many people do in that situation, is just, you know, quietly excuse myself, go and cry privately somewhere else, because God forbid I make him feel awkward. And so it just made me think lots of different things. And that's the point, really. 3 points just to sort of summarize where I'm coming from on this. And I think it's maybe why we should lift the veil on this sort of the high drama that goes on during this sort of murky, secretive first trimester. Because maybe if we celebrated the 3 out of 4 pregnancies that do make it, maybe in the open acknowledgement of the 1 in 4 that doesn't, you know, we could help scotch this myth that pregnancy has a 100% success rate. That could maybe lead to, you know, maybe kinder conversations and a bit more support for women, because it's a very lonely, isolating experience. And I remember I used to panic on behalf of women when they announced their pregnancy, you know, before the second trimester. And I'd worry, oh my God, do they not know the sacred rule? You know, they've got to wait until it's 12 weeks. But when I think about it, you know, why? What would I think was going to happen if, God forbid, that woman did lose the baby? Would people have thought, oh, how foolish she was? And then, you know, oh, serves her right for counting chickens. Of course not. I'm sure the typical response would have been the one I had, or the typical response I had when, after years of being secretive about it, you know, I finally told people, and they were so kind and supportive. And after I wrote my piece in the Times, I was so surprised and touched by the number of people who came up and sort of said behind whispered hands, we know what you're going through because that happened to us as well. You know, older family friends in their 70s who still remember their experiences, and neighbours, mums on the school run, just so many people. And I understood why it was called the Secret Sadness Club, because suddenly everyone around you, while you're going through this awful thing, you don't realize that so many people of the women you will have spoken to during that week will know exactly what you've gone through because they've gone through it themselves. So that's one thing for our just emotional well-being. But another practical point, just finally, is that if I had known more about what to expect, particularly the aftermath, the physical aftermath, I might have been more able to spot the symptoms a year later when I started having the ectopic pregnancy. But instead, I had just sort of ignored 2 weeks of strange, irregular bleeding and just thought, oh, that must be one of the many things that, you know, is one of the miscarriage things they don't tell you about. In fact, it was my body sort of giving me a warning that an egg had implanted itself in the wrong place and that I was hemorrhaging inside. And if I'd picked up on that sooner, maybe I wouldn't have, you know, collapsed in the middle of nowhere and had to be rushed to hospital for emergency surgery, not knowing whether the surgeons would be able to save my reproductive system. So it all got quite dramatic pretty quickly. So that there's so many reasons why I think, you know, we should be more open about this. And that's my sort of initial thoughts on this. So I don't know what you think about that, Lesley, you know, in terms of this first trimester. I'm interested in what you think. You know, where did that come from? I always used to think it was a clinical thing, you know, it was for good medical reasons, but I realize now maybe it's more social convention.
Yes, and I think it's rooted in history as well. So my mother and my grandmother didn't have ultrasound to be able to diagnose an early pregnancy, just via fetal heart in the early pregnancy assessment unit or in their local gynecology clinic. They just had to wait for 2 or 3 periods to be missed, and then the bump would start to show, and then they were okay. They knew that some of their friends had problems and had bleeding and then seemed to lose the pregnancy. But you know, it's only relatively recently that we've been able to buy pregnancy tests over the counter. You know, in the old days, you had to go along to the doctor and wait for 2 weeks for the result. It seems quite expensive. But in answer to your question, I think what hasn't really changed is the fact that the vast majority of miscarriages are to chromosome or genetic abnormalities in the embryo. And what I want to impress on the audience today is that the vast majority of those miscarriages occur in the first trimester. In fact, really before 10 weeks. So by the time you've got to 10 weeks and you've seen a fetal heart, say at 6.5, 7, 8, 9 weeks, you're probably good to go in the sense that you're relatively safe. So one of the points I would just like to emphasize to anybody listening today and joining us here at this WOW webinar is that if you have a miscarriage after 12 weeks of a baby that is grown to 12 week size, it's really important that you present to a specialist clinic straight away, because first of all, there aren't that many pregnancies, only 1 to 2% that miscarry after 12 weeks. And often those women have a particular, they may have 1 or possibly even 2 different causes. So it's much more likely that they've got an underlying problem, not just that the genetics of their baby were abnormal. So I think that's important. And I think the other thing to say is that many, many times a week, women will say to me, well, why do I have to wait for 3 to be referred to your clinic at St Mary's? And in an ideal world, I would see women who'd had 1 miscarriage or 2 miscarriages. The problem is that if they were the eligibility criteria for the clinic, I wouldn't be able to see very many people because we will be completely flooded with requests because it is such a common problem. So we've had to ration it, and it always seems very cruel, but only so that we can continue to have the funding to carry on to look after women in the specialist unit that's looking for underlying causes of women who've had 3 or more losses. And the reason is that about 5% of women will have 2 or more losses, and about 1% of women will have 3 or more losses. And although 1 and 5% may not seem like a big difference, it's the difference between investigating 1 in 100 couples and 1 in 20 couples. So you can see from when you're trying to design a service to cope with the needs of everybody, you've got to think about that. But I would say as well that I think going forward, what the research which is now into clinical practice has shown us that there are other pointers about a woman's history that would alert you to start investigations at an earlier stage. So for example, Lucy, if you told me that during your pregnancy, of your successful pregnancy, you'd had a problem with delivering prematurely, or that the baby hadn't grown very well, or had been caused some concern and was thought to be small for dates, or that when you delivered the placenta seemed to be very stuck and gritty and small, then that immediately alerts me to the fact that you're more likely to have, for example, a blood clotting disorder, which may be contributing to your then miscarriages. Because when we first started the specialist clinic at St Mary's, we looked at all the women that came along to see us, and we found that in addition to having 3 or more miscarriages, 3 or more early miscarriages, when they'd previously had a successful pregnancy, that there were more complications in those pregnancies, suggesting that they had an underlying problem. So I think it's being aware of all of those factors. And I would like to also say that one of the most important things, if you've had repeated episodes of miscarriage, is to try and ensure that if you do have the misery of going through a further loss, that you try your very utmost to get those tissues, if you can save some, analysed for genetic abnormalities. Now, sometimes people will say when they are having an acute bereavement because they're miscarrying, well, how does that help? But in fact, my experience is that most of the couples that I see, and certainly all of the women I see, can cope with bad news if I can explain why it happened. And I'm going now back to 1986 and my Cambridge training days. What it was so difficult is when they don't know. So if we can give at least, even if it's not even if we're not able to celebrate a successful outcome of the pregnancy, if I could explain to you and show you a report that explained that this baby had a genetic problem that was incompatible with a live birth, paradoxically, that would give you a bit of comfort, and it would also give you some reassurance that we hadn't missed a major problem that we could have done something about. This was random, it's sporadic. I can't change that because it's to do with aging and the quality of your eggs. So I'm not trying to be dismissive about it, just to say how important it is, if you have had repeated episodes, to see whether you can be referred to a special clinic to get some investigations, and also to ensure that if you do have to go through the trauma of another loss, that at least you get information from that, which will really help to determine how you're looked after in the future.
Yeah.
Back to you, Lucy.
Yes. Yeah, we're having lots of questions, which is great. One that's come through from Aoife, she asked, what is the risk of a subsequent miscarriage if you've had one? And, can you do anything to prevent a miscarriage, if you're at further risk after, having had a previous history of miscarriages?
Well, there are some women who appear to be more likely to have repeated miscarriages, and there are some medical problems that increase the risks of miscarriage. But I can be very reassuring. The vast majority of women who are listening to this webinar today, I can say that after a single miscarriage, you're far more likely to go on to have a successful pregnancy next time. And I would also say that the vast majority of women whom I see at the specialist clinic at St Mary's do go on to have a successful pregnancy. And one of the conversations I have most frequently in the clinic is, if I'd been investigating you, Lucy, and we made a plan as to how we were going to look after you next time, first of all, my most difficult problem will be convincing you that not having found a problem is really a good prognosis for you, the best prognosis for next time. And the second is ensuring that you feel that you know all of the tests and the investigations that have been done, and that you feel really quite empowered by what's happened. And I would really strongly recommend that anybody who's listening today goes on to Amazon and gets hold of a copy of my paperback, which is called Miscarriage, What Every Woman Needs to Know. And it's published by Orion, and all the proceeds go to the Recurrent Miscarriage charity. But in that, I talk to my audience who are reading it, saying, the more expert you become about the causes of miscarriage, the more comfort you will be able to have and the more confidence you will have managing your next pregnancy. And I finished that paperback, and it's several hundred pages, so it's a good long read. But I finished that paperback by saying, please be brave and try again, because the vast majority of women I've ever met come back with a successful pregnancy. And if anyone visits me at St Mary's, they will see all of the hundreds of photographs over the walls of the department of all our successful babies on the Rogues Gallery, some of whom had very long paths to get there, but they all get there in the end. So please don't give up.
And Vicky has also been asking, she wanted to ask Lesley if you had any advice on pregnancy after loss and how to deal with the anxiety, particularly in scans. And this resonates a lot with me, because I was I was in such a state of anxiety after, you know, my experiences, that when it eventually did happen, I was terrified.
Yes.
The toilet cubicle became my enemy. I was terrified of going in there, and I was in total denial. I didn't want to speak about pregnancy, and to the point that it possibly wasn't very healthy. So I just wonder if there's any advice you have on people, you know, dealing with that, because obviously we're also scared, you know, once we finally do get pregnant, of possibly the same thing happening again.
Well, very good question. And the first thing I would say is that there is no evidence that waiting for 3 months or longer trying to become pregnant again is of any benefit. So as soon as your normal period comes back, there is no reason why you shouldn't try again. So don't wait for long periods of time. There is no evidence that that improves the situation. Now, in my experience, women fall into two camps in early pregnancy. They are either wanting a scan every 10 minutes to make sure that the heartbeat's there, or they have a reaction like yours, Lucy. Oh my God, I don't want to go to the toilet and I don't want to go for a scan, because that's what I associate with bad news. So the one thing I've eradicated from my vocabulary is don't worry. Because I think if I tell someone who's had repeated miscarriages, don't worry, I mean, I really think if someone said that to me, I'd feel they were talking down to me. So I don't say don't worry. I always say, I know you're going to be worried, but what we're going to try and do in the early pregnancy clinic is give you as much support as we can to help you through this very worrying time. And we actually say, you know, we'll continue seeing you until you've got to 11 or 12 weeks. And then when you've got the confidence to know that this pregnancy is ongoing and is very likely to be successful, we then graduate you from the clinic and send you back to your local maternity unit. And again, going back to that miscarriage book, I think there are lots of tips in that about how to look after yourself in the next pregnancy. Please don't blame yourself for what's happened, because the vast majority of women have not caused the miscarriage. It's just written in the genetic blueprint in that embryo. And that's either come from their egg or the sperm. It's nothing that they can do about that, unfortunately, but that's how it is. So please don't blame yourself. The vast majority of women don't cause themselves to miscarriage. Please carry on doing your normal exercise and eating a sensible diet. It's sensible not to smoke and not to drink alcohol. But, you know, if you have a half a glass of wine, it's not going to be the end of the world. So just be sensible about it. And just, I think, information here is power. The more informed you are, the more knowledge you have about the causes of miscarriage and what you can do to access help in early pregnancy, the more confident you'll feel and the happier you will be at a very worrying time.
Leanne is asking, are you more likely to miscarry if you're over 40? How significant is age?
Well, age is important because we know, and this is data that goes back to when I was a consultant, or it was when I became a doctor, that after the age of 35, the incidence of miscarriage does increase because of the age of the eggs that we're ovulating or producing. So you and I, Lucy, were born with all the eggs we'll ever have. And as we grow older, they get older and less robust. Whereas I think most unfairly, men make a new set of sperm every 3 months. Now, we haven't got the time to talk about how unfair that is just now. Let's just focus on what we can do as women. So yes, and that of course, because of the aging of eggs and the increased risk of miscarriage and other complications due to chromosome abnormalities, genetic abnormalities in the eggs, and then therefore the embryos that are created. That's why after the age of 40, you do have an increased risk of miscarriage. But again, I often say to women, look, you may be 41 or 42, but then I only see women who've had problems. I don't see the women who've had 3 successful pregnancies, only the ones who've had problems. And I want to repeat again, the vast majority of women I see go on to have a successful pregnancy if they stick at it. So please don't give up because you're 40. There are lots of very healthy babies born to women in their early 40s.
And another interesting question, Robin is asking if being overweight has an impact.
Yes, it does. And I think this is a very important, and it's an excellent question, Robin, because over the years, I found it very difficult to talk to women about weight. Sometimes it's a bit taboo. You shouldn't be talking about weight and obesity, but we know, we've got very clear data, that women who have a BMI, a body mass index greater than 30, do have a markedly increased risk of miscarrying. And I think it's important to explain why that is, because the weight side of it is the one bit that I can't sort out for them, and they have to sort out themselves. So rather than feeling, and I often say, I'm not trying to read a lecture about this or make you feel bad about your weight, but you have to understand that the fat is not padding. It's actually an organ in its own right. Just like your skin is an organ, it's all over your body, but it's an organ. And we know that in women who've got a higher BMI, who've had repeated miscarriages, that they produce chemicals called cytokines in their ovaries, which actually have an adverse impact or poorer impact on the way the woman's ovary functions and the way she ovulates. And importantly, we know that women who are very overweight also have increased number of these chemicals in the womb lining, in the womb cavity or the uterine cavity, which actually impairs the quality and the depth of implantation when the embryo is trying to burrow in and take a foothold at the beginning of pregnancy. So one of the most important things you can do if you are overweight is to try and get your BMI down. And that's really important. And I would also add there, please don't do it by starving, because if you starve yourself, your body just becomes better at scavenging on fewer calories. You need to burn it off with an exercise and a diet program. But it's a really important question.
Camilla is asking, she says that unfortunately she's gone through a second miscarriage, and she was wondering why we're not offered testing after 2 miscarriages. She says, I feel totally lost and scared to try again with no option on the NHS to find out why this has happened or why my babies didn't survive.
Oh, thanks, Camilla. And I'm sorry you've had that recent second loss. And I wish we could open up the clinic doors all the time to people. I was trying explaining earlier that because the sheer numbers, and it's such a common problem, we're not able to do so. But I have got some hope for the future, because I've been talking to some researchers, some genetic researchers recently, who are developing ways in which we can do non-invasive prenatal testing as early as 7 or 8 weeks into the pregnancy. And now you will know, if you've gone on to have a baby, and as you have, Lucy, you probably had nuchal scanning and blood tests performed at 11, 12 weeks, and that's called non-invasive prenatal testing. But we know now,
I have no idea.
but we know now that we can actually get the signal from the cell-free DNA from the baby in the mother's blood at an earlier stage. So my hope is that in the future, we'll be able to test women. At the moment, it's too expensive to do, but we're working on it. We'll be able to test women who present at, say, 8 weeks or 9 weeks with a miscarriage, and we can identify which of those pregnancies are genetically abnormal, i.e. we couldn't change, and we would also be able to identify those women who've got a genetically normal embryo, which they're miscarrying, which would then suggest that there's something that we've got to try and find to help protect her and the normal embryo in the future. So it's not an answer for this week, but it's an answer that I hope we'll be able to implement, later on, later this year or next year. Let's hope so, if we can find the research funding to do that sort of thing for everybody.
We've got an interesting question here from Ricardo, and he is asking if, for people who've had problems of recurrent miscarriages, whether egg donation could be a likely fix. He said that he and his partner have had recurrent miscarriages over the past 5 years, and wondering whether, using a donor's egg might be a possible solution, or at least give them a better chance.
Well, Ricardo, that's a really important question. And if I had £1 for every time I was asked it in clinic, I could have funded wellbeing of women to do all that research I want to do. But the reality is that, in fact, this is not a cure for repeated miscarriages if you are able to get pregnant yourself spontaneously. So if you can't get pregnant on your own and you're needing to have fertility treatment, then yes, IVF is a good option because you can't actually circumvent the problem. But if you're actually getting pregnant on your own, fertility treatment is not the answer to it. However, we know that in women who are older, if we believe that the miscarriages are occurring because of the age of her eggs, that may be an option to consider having a donor egg. And I don't think there's a right or wrong about it, Ricardo or Lucy. I think it's just what's right for that couple. So I will often have the discussion with a couple who say, well, I've read on the internet that I should be going off to have IVF to cure my miscarriages so that I can test the embryos and make sure I get the good ones put back, the normal genetic ones put back. But I just want to remind everybody on the webinar today that that doesn't increase the number of live births. It may reduce the number of miscarriages because then the IVF unit doesn't put back the abnormal embryos, which might have miscarried. But remember that when you come along wanting a cure for miscarriage, you don't want to stop your miscarriages. What you want is a live baby. Yeah. So the IVF with egg testing and only putting back the good ones doesn't increase the number of live births, and it doesn't shorten the time at which you get to that live birth. So I mention that because there's been really good studies that have looked into this. So I don't want a couple who can get pregnant on their own to go and spend an enormous amount of money and emotional expense on very complicated IVF treatment and then not realize until later that this was false expectation.
Mm-hmm. There's a question from Jennifer, and she says this is very timely, this session, because she's about 11 weeks pregnant, but sadly there has been no heartbeat detected and it seems her baby isn't growing properly. So I'm sorry to hear that, Jennifer. She's having her appointment tomorrow and she's wondering just what questions she should be asking at this point to make sure she's got all the information she needs and how to move forward. So obviously it's a very scary time.
Yes, Jennifer, I'm so sorry. And I don't know whereabouts that you are in the country, but I'm sure that when you have your appointment tomorrow, I hope you will meet someone very sympathetic. And I think if this is the first miscarriage or the second or whatever, or if it's been a repeated miscarriage, I think you can ask the question, is it possible to have the tissues tested so that you will understand whether they were chromosomally or genetically normal or abnormal? And it may be possible, even in our COVID world, it may be possible to have a manual vacuum aspiration in the clinic of those tissues, or even have a surgical procedure to get those tissues. And if the hospital isn't able to offer it a formal genetic analysis of the tissues because it's your first miscarriage or your first pregnancy, you could always ask them if it was possible for you to send those off privately. I know that's not ideal, but if you need that answer, that is a workaround that I've offered some of the ladies I've been looking after recently. So remember, in pre-COVID days, often the women who come into the recurrent miscarriage clinic, I would bring them in for a procedure in order to get the tissues quickly, to get the best chance of getting an answer. Because of COVID, it's a bit more difficult bringing healthy women into hospital because we don't want them to be infected in hospitals. But I think if you talk to the team when you have your appointment tomorrow and explain to them how important it is for you to have some answers to why this has happened, I'm sure they'll do their very best to help you. And you can always email us, email me at Imperial, and we can give you some additional advice if that's helpful.
Are there any, I'm just wondering, are there any particular myths or any sort of recurrent misconceptions that you often hear, Lesley, that you think, might be helpful to, maybe we can bust a few myths here. What are the most common misconceptions you often hear?
Well, I think this one about I've been told that I mustn't get pregnant now for 3 months or 6 months. I think that's complete rubbish. And it's really important to get rid of that myth because, of course, our reproductive clocks are ticking and we don't want time to be wasted. I also think that, people say, oh, well, she worried herself into a miscarriage. I think stress is very much an accompaniment to miscarriage, but I don't think it causes miscarriage. And the other thing that lots of women I see worry about is that they had a glass of wine or they ate something, or they did their yoga class, or they went on a run and then suddenly they miscarried, or they got on an aeroplane and they thought that the aeroplane journey or the travel had caused them to miscarry. It's highly unlikely. When you think about it, you look at those pictures of this little tiny embryo inside the womb wall. I mean, for the first 12 weeks, it's protected by a pool of water, which acts like a baffle. And then you've got the placenta, which is protecting it from everything coming in from the mother's blood. And then you've got a big, thick muscular wall, which is the uterus or the womb. And then it all sits behind your bony pelvic girdle. So, until it's got to the viability stage, it's actually very well protected. It's quite a clever design, human pregnancy, in that respect. So it's highly unlikely that anything that you do in early pregnancy is going to cause you to miscarriage. But if you happen to have booked that flight to, I don't know, Malaga, it seems a bit mad now talking about holidays in COVID, but let's pretend we'll get back to somewhere normal sometime. If you booked that holiday and you were on that plane and you miscarried, you sort of think, oh, well, perhaps it was because I was on the plane, but it really is not the case. It's just because most miscarriages occur very early. And often you're getting on with your life, or you've made plans and you then find yourself to be pregnant, and then events happen. So please try not to beat yourself up. Beaten up miscarriage sufferers are, they are so difficult to help. So just be kind to yourself. It's highly unlikely that you've done anything to cause the miscarriage.
Yeah, we've got a question about that. One lady had said she found a lot of the language associated with miscarriages often about blame and guilt. And I know, I kept it quiet for so long because part of the reason was that I didn't want to be seen to be failing. And I put so much pressure on myself, and I just felt that I was, it was really difficult, I found, to deal with in terms of, the guilt and the blame that you put on yourself.
Yes, the guilt and the blame, and the did I do something wrong, and why has my body failed me?
Yeah.
And then there are many women I see who are really, really distressed that they haven't been able to give their partner the child that they'd assumed they would just be easily able to do. So I think it's so important to talk about it with your partner, and to try and as I go back to that miscarriage book, please get a copy, because I think it will really help many of the women who are too far away from me to come to get the benefit from our clinic. Just make sure that you understand what the causes are, how common the problem is, and what you can do to help yourself. But please don't beat yourself up, because it's highly unlikely that if you're able to get pregnant easily, that you've done something awful to the baby. It's just due to random bad luck. And stick at it, because you will be able to achieve a successful pregnancy if you persevere.
And that was the other thing that I also found very difficult, was, in the early stages, obviously you're keeping it quiet, you're being discreet about things. And so, other people in your, in your workplace, other acquaintances obviously don't know what's happening. And so if it does go wrong, it's difficult, because how can other people help support you mourn for something they didn't even know was there? And I know other people have spoken about this. I know Stella Creasy, the MP, she spoke about having to endure repeated miscarriages while continuing on, in her work as an MP, holding meetings, going to constituency meetings, all while sort of enduring this private misery. And as did the comedian Catherine Ryan. She talked about, she had an awful experience where she had to wait, I think it was about a month for the embryo, for the pregnancy to sort of leave the body. So she was doing gigs for a month, having had a failed pregnancy. And she said it felt like she was a walking tomb. And I think for me, psychologically, that was the hardest bit, is that dissonance between, carrying on with normal life, and I just find it amazing that there's women, I think there's like 600 women in Britain a day who will be going through this, and they're all over the country, taking other kids to school, holding meetings, doing their work, going to Tesco's, while all the time that there's this, there's a baby dying inside them. And I found that disconnect was a really hard thing to deal with. And again, it was not helped by the fact that other people didn't know. So you were even more isolated.
Yes, I think all of those, and you've put them so eloquently, Lucy. This awful feeling of, well, how didn't I know that the baby died, is one that I hear repeatedly. So in fact, I think those women become very, very distressed because they didn't know it, and they feel that somehow they've let themselves, or they've let their bodies down, or their bodies have let them down, because why didn't I know that this baby wasn't continuing to live? And I think that has become more of a problem during the pandemic lockdown, because in the past, if you come along to the clinic and the diagnosis had been made that there was no heartbeat, then you would be given options. That you want to come in and have a surgical procedure to remove the tissues, or did you want to take some medical treatment to help the womb expel it, or would you like to be managed expectantly and just wait and see for nature to take its course? I think because of the pandemic, we've had to verge more and more to, well, manage it expectantly or take some tablets to help expel it. But I would add here that, you know, the misoprostol and the medication to help the womb expel the tissues when we've confirmed that the miscarriage or the pregnancy is no longer ongoing, I would strongly advise women to pursue that route rather than necessarily wait for weeks and weeks, because it can take quite a long time to draw a line under it. And in my experience, particularly in my recurrent miscarriage clinic, when the diagnosis is made that the pregnancy is no longer viable, what most of my women want to do is to draw a line under it, get as much information about it as possible to help for the future, and then move on. So I'm always very sympathetic, and I've got a wonderful team at St Mary's who all know that sending women away to just waiting for it to happen isn't the optimum for them. So do try, if you've had a problem, to talk tomorrow, the lady who is going to see the person tomorrow, and see what they can do to draw a line under it for you. I'm sure they'll be able to help you.
I was going to say, actually, it was amazing how much progress has been made as well, and how things have, particularly, you know, in the health profession as well. I mean, I had chats with my mum, and I remember when I was younger being told that I was going to have a sibling and waiting expectantly, and then the sibling never arrived. I might have been told what happened, I can't remember. But even now she's drawn to tears, moved to tears by the way it was handled and the way the news was broken to her by an older male doctor. What can you say about the progress that's been made?
Well, I think we have made enormous progress. People on this webinar today, they'll think we haven't made enough progress. And of course, you must never be complacent. We can always do more. Like I was talking a bit earlier about how we've got this possibility now of making a diagnosis about which embryos are normal and which are abnormal. So we can then, if you like, select those miscarriage sufferers who need to be fast-tracked for further investigations, and not have to put them through all those investigations if it's not appropriate. But as you say, we have made big progress. I mean, we didn't know when I first went into this field and did my first WOW-funded project in Cambridge, we didn't know about the phospholipid syndrome and blood clotting abnormalities and how they contributed. And we now know that that is the commonest treatable cause of repeated miscarriages. And the treatment for this, which is a combination of aspirin and heparin injections, is now the gold standard, and it's now the gold standard across the world. So I was talking on a webinar in Australia the other day, in the middle of the night, I might add, and you know, that's the gold standard there as well. And we've made big progress with lots of genetic clotting abnormalities, genetic mutations that we inherit. It's part of our genetic code, and sometimes they can contribute to later pregnancy complications. So we've learned things there. We're always looking at other tests that we can try and develop to understand more about the causes of miscarriage. So for example, I've got some wonderful younger colleagues at Imperial who are looking at the microbiome. So they're looking at the microbiological bugs that live normally in the vagina and seeing whether there are different populations for women who've got repeated miscarriage compared to women who have repeated live births. And that's looking very promising. And I must say, I emphasize that in the microbiome work, because as I look back on my career in medicine, so many things have turned out to be due to bacteria and bugs. You know, when I was a very junior trainee, we used to treat stomach ulcers by operating on people, and now we give them an antibiotic to get rid of the bugs in their stomach lining. So I have every hope that if this wonderful team of youngsters now who are doing this work with the microbiome, that we'll have some fabulous new therapies to offer, because obviously when you discover that there's a particular type of they call it microbiome, that's associated with a problem or a complication of pregnancy, then the race is on to how can we tweak that and change it so that it's a more favourable environment for this embryo to grow.
That's really interesting.
It's really fascinating. So I think the answer is we've learned a lot, but we must never ever rest on our laurels, and there's always more to learn, there's always more to gain. And it's such an important part of life. And miscarriage is so common that we've really, really got to keep pushing for the research funding to get to those answers.
Yeah. You know, somebody was asking, you know, why do people always say, oh, it's nature's way, it's meant to be? And I'm also wondering, following on from that, whether that attitude maybe sort of stopped the funding from happening in the past, that maybe that there was a disincentive there to find out, well, actually, maybe there are cases where this is preventable, and there are reasons behind it.
Yeah, I think it maybe it's sort of almost like a fatalistic, well, that's what happens. And
Yeah,
and
sure.
that's one of the reasons why I got involved in this field, because I saw so many women in floods of tears at 4 o'clock in the morning in that hospital in Cambridge. I thought, well, we must be able to do better for women. And I think that things have improved, but they're not perfect. And I think also, Lucy, and I think you'd agree with me here, women's health is not prioritised. And I think that's a real mistake, because when you get it better for women, you get it better for everybody. I mean, because as I was saying earlier, women, you know, they number 51% of the population, they produce the next generation of humans, but they also influence the health behaviour of everybody else. So when you get a woman who's found out all about her miscarriages and she's read up about all the different things in her diet and her lifestyle that she can improve, she doesn't just keep all that to herself. She tells her children about it, she tells her partner about it, she tells her sister, her next door neighbour, her community about it. So I think that one of the things that we've got to do better in our NHS in the UK is use women as ambassadors to improve health, because I think they're an incredibly valuable resource. And the more that we empower women to understand what they can do to improve their health, the more traction we'll get, because they influence everybody else.
Yeah.
We're great ambassadors.
Yeah. I think there's a lot to be done about tackling the silence around it as well, because so many of us are quite resilient, and women's health can be complicated and messy and brutal, and we kind of go through a lot sometimes, and maybe there's a sense that it's just one of these things we have to deal with, and you just have to suck it up and get on with it and not complain about it. And I think that's maybe when there has been a few cases, high profile cases. Chrissy Teigen, for example, influencer, she was incredibly candid, sharing, sort of a live commentary almost of her recent pregnancy loss. And I think possibly maybe more people talking about it and just being open. We all know this happened, but being more open can only be a good thing, surely.
Absolutely. I mean, sometimes when I'm talking to people at Department of Health, and particularly male MPs, they sort of look a bit sort of, oh dear, where's she going to go now? And they can just about cope with the miscarriage thing. But when I start talking about periods, they sort of, oh, and I said, but you can't go, ooh, like that, because menstrual periods affect most women 12 times a year for 35 years of their life. If any problem that affects a man that frequently would become front and center, we've got to sort this out. It's part of everyday life. And instead of not talking about it and them having to take quiet time off work, or not able to look after their kids, or as you said earlier, Lucy, go to Tesco's and get on with their lives, I think what we've got to do is to find ways to help them manage the problem so that it's not interfering with their day-to-day life. So I think it's really important. And I think that if everybody on this webinar could do their bit to say, we want to prioritise women's health issues, the common things that affect everybody. I think there's been a tendency in the past for people to think, well, as it's so common, people have just got to get on with it. And I don't think that's the case. I think we've got to talk about quality of life now. And also remember that if you help women to manage miscarriage and have less complicated pregnancies and have less painful, problematic periods, they'll be able to contribute more to the workplace and to their family lives. And so it's a win-win. Get it better for women, we get it better for everybody.
Absolutely. Couldn't agree more. I wonder if there have been many questions. I hope we've managed to answer many of them. There's one lady who has saying she's suffered two silent miscarriages, and it seems to be an uncommon type of miscarriage. she wondered whether it could be linked. This goes back to what we were talking about earlier, but she's sort of asking herself questions. Could it be linked to my immune system, or the fact I've had epilepsy and since as I was a child, and have taken medication for many years? I'm 42. I mean, obviously, we're not asking you for diagnoses, Lesley, but again, maybe this touches on some of the previous points we've made. But I just wondered if there was anything you could say to this lady, Parveen.
So I think try and get as much information as possible. It's Parveen, yes, I've just seen her thing. And yes, of course, you're worried about your age now. Please get hold of that miscarriage paperback. And if you need to see something, you can always contact me. I'm going to put my email in the chat box here, because we can always find someone who can see you. I don't know where you are, Parveen, but I'm sure we can direct you to somebody locally if you're not in the London area. There's always things that you can do, or you can go and see somebody privately if your local NHS clinic have got criteria that don't make you eligible. So it may be, I often see women for a one-off consultation so that they can get some information and organize and then decide whether they want to have further tests or not. And sometimes when I've explained the magnitude of the problem, how common it is, and how everything else about their particular history or their previous pregnancies doesn't make me feel worried or concerned, that's often enough to give them the confidence to start again. And then I get a lovely letter saying, oh, and here's a photograph of my baby, and we didn't need to come back to you. So just keep positive about it, Poppy, and I'm sure it'll be possible for you to be successful.
And one question referring back to what we're talking about, sort of bleeding and all the difficult conversations around that. One lady who'd like to remain anonymous had said that she had one very early miscarriage, and then the following cycle began bleeding for like a 10-week stretch. And she was very surprised at how long that went on. And again, she's not asking for specific diagnosis, but she's just wondering, is that common? Should we expect that, or is that particularly unusual?
No, it is unusual. I mean, I've seen it many times, because as I said earlier, Lucy, I only see people who've had problems or who haven't been sorted out elsewhere. But I think to bleed for that length of time suggests that she may have some tissue left in the womb, or possibly she's got a little polyp there, or something that needs to be looked at. And certainly an ultrasound scan and an appointment at the local clinic would be a sensible first step. And then you've got a bit more information with which you can decide what's best for you to do next.
Yeah, because again, that's what really shocked me, just the aftermath, the physical aftermath, how long it takes.
That's right. And that's why I was saying earlier that I know I tend to see women after repeated episodes of miscarriage, but I do know that if I had to say what was the common thread amongst them all, it was wanting to know why. And number two, let's draw a line under this and get on with life. So I think that if it does go on for a very long period of time, you need to go and seek help to try and shorten it and just make sure that everything's okay, so that you can get back onto your normal cycles and try again at the earliest opportunity.
Okay, we've got a question. I don't know if you can see that one there, Lesley, from Francis, who says she's 30, she's got 3 children and has had a recent loss, and she and her husband were devastated and she nearly died. She said she's now worried because she wants another baby, but she can't get past the guilt of my poor husband and what he went through. So he's worried about losing her.
Oh, and my heart goes out to both of them. I mean, it's an awful situation. He must have been very, very scared. But I think it's unlikely that having had 3 successful pregnancies, I mean, I'm not sure how Francis, what your last delivery was. I mean, unless you'd had repeated cesarean sections, I think it's unlikely that you're going to have a major problem again. But again, you probably need to tell me a little bit more about your obstetric history and what happened during those 3 successful pregnancies before I give you black and white advice. It's often very helpful to get some counselling if you've had an event like that, because it is very, very frightening. And I often meet the fathers who really, really are shell-shocked when they are part of a delivery that is very traumatic or very gory, because they're in a situation where, the person that they love, and in fact 2 people that they love are in this, are in extremis, and there's nothing that they can do to help. So I really do empathise with the feelings of that, but I'm sure that some careful sort of debriefing about what actually happened and why would help you both come to terms with that, and hopefully then you'll be able to move on.
Yeah, and of course it is, it's hard enough for women to talk about it and what's happening to our bodies, but obviously it's difficult in a different way for their partners and the people who love them. And I imagine it can be very difficult for the fathers too, because they've lost a pregnancy that they would have been hopeful for, and they are maybe shut out a little bit because it's such a physical thing that's going on with us, but it can be, there's not very many places for them to turn either, is there?
No, and I think the sort of archetypal British macho man doesn't do well in a situation where they feel that they can't help, or they're completely out of control. So
Yeah.
I think it's wonderful that Frances is asking a question like that, and that's her husband's response. I entirely understand it, but I think what they need to do is to sort of try and unpack the events quietly and objectively with someone who knows something about this field, to give them the reassurance that he needs, and hopefully then they'll be able to go on and have another attempt at a fourth child. But I think the grief that men feel is very real and often not acknowledged appropriately. It often turns to anger. I mean, I remember back in the 1980s in Cambridge, when I was talking about those women when I first got involved, one of the things that was always the trigger for me was that the partners coming along and getting very angry that the woman wasn't being sorted out surgically or whatever. And it wasn't because they were angry at me, it was because they were angry that they couldn't help, and they couldn't make it go right.
Yeah.
We've all felt that frustration and anger when you just can't make a bad situation get better.
Yeah, I know. I think in my case, my husband did get quite a fright when, I collapsed that time, and it didn't help that we were in the middle of absolutely nowhere, and he had to get me
It's scary.
to a hospital, and it was an absolute nightmare, and I was sort of in and out of consciousness, and it was only afterwards really that I realized he'd been quite traumatized by it too. It was quite the things that happen to us as women, it can be pretty testing for all concerned.
But isn't it extraordinary that we are the guardians of incubation for the next generation? I think women are just extraordinarily wonderful. I really do.
It really is. I'm just going through
so many questions. It's giving me epilepsy watching them all coming up on the screen. So I hope we're doing.
This is fantastic, and this is what I mean. Like when you start talking about it, it feels very taboo at first. You feel like you've got this unique curse, and then when you start speaking, you suddenly realize, so many people are going through exactly the same thing.
Yeah. And I think, just as we're winding up, because I think we've only got a few moments left, I think that's a really important point, that, one of the things that webinars like this can achieve, and one of the things that wellbeing of women can achieve, is to actually demonstrate on a practical level to women that they're not on their own. They're part of a family of women who have experienced this very, very common complication. And by talking about it and sharing their experiences, we really are helping many others. I mean, there'll be lots of people who are on this webinar who didn't want to commit to asking a question, but I think we'll be reading all the responses and the questions avidly, and hopefully will give them the sort of the courage to ask more questions themselves going forward, and to demand more. We need to demand more of our health service, because, as I said at the beginning, we haven't prioritised women's health, and there's so many things that we can do to make women's pregnancies, and particularly the miscarriage problem, much, much less traumatic. So let's all work together to do it.
Yes, absolutely. I'm incredibly grateful for the amazing sensitive support I received from the NHS and from all the people I met. But if anybody else is feeling a bit worried, it's just knowing the right questions to ask and sort of demanding them be answered, rather if you're unfortunate enough to get that response when it's just a shrug, it's good to know what you're meant to be asking, and it helps you feel empowered. And also just sharing the other stories of other people. I feel I've got a lot of comfort from reading about other women and just speaking with other women about their experiences too. So I hope we've managed to help answer some of the questions.
And Lucy, can I say thank you on behalf of Wellbeing of Women for being with us this morning? You've done a wonderful job of sorting out the questions and sharing with us your own painful experiences, both the miscarriages and the ectopics. It's been wonderful to have you here. Thank you for your generosity, and thank you for the bravery of writing that article in the Times, which I think it went rather viral, didn't it? It was very, very well received by so many of the women, and I think that's why there are so many people on this webinar today. So Wellbeing of Women is going to continue to fund research into this really important aspect of women's healthcare. Please, 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 everybody who's on the webinar today, please donate so that we can make it better for women and better for someone you love.
Absolutely. Well, thank you so much.
And on that note, I think we're going to close the webinar. Thank you to everybody, and I hope that you'll join us for future Wellbeing of Women webinars. And Lucy, our wonderful host today, thank you so much indeed for being with us. You've been absolutely fabulous. Thank you.
Thank you so much.
Bye-bye, everybody.
Bye-bye.